Right. Good evening, everyone. Thanks for joining us for our second bare bones session. This week we're doing wrists. So we've got some great talks. Kriti and Alison, who are two members of the BOTA committee, are going to do some basics of the topics that we're doing later on this evening in our Sunday supper. So hopefully it'll give you a good grounding. And if you guys want to come along to that, then we'll share a link in the chat afterwards. So without further ado, we'll start off with Kriti.
One second, share my screen.
If you have questions, please use the Q&A box at the bottom.
Okay, can you guys hear me okay? Perfect. Okay, so today I'm going to be talking to you all a little bit about a crash course on carpal tunnel. So we'll start off with a little bit about the anatomy. So the carpal tunnel is comprised of a floor that's made from the carpal bones themselves, and then the roof is made from the flexor retinaculum, and that's the part that you release when you do a carpal tunnel release, and that attaches to the scaphoid tubercle and the trapezium on the radial side, and goes across and attaches to the hook of hamate as well as the pisiform on the ulnar side. So there are 10 structures that run through it, and you may get asked this in your exams. So there are 9 tendons, 4 which are the FDS, 4 that the FDP that are deeper to that. And then superficial to these tendinous layers, there's the median nerve. And within the carpal tunnel, slightly on the radial side, lies your flexor pollicis longus. Now, some people are under the misconception that the FCR also runs within the carpal tunnel, but it actually doesn't. What it does is it runs within the actual retinaculum, within the sheath, and it's the most radial structure. In terms of surface anatomy, you just need to remember that the distal wrist crease aligns with roughly the entrance of the carpal tunnel. So moving on to history taking. So when you're in clinic and you're seeing these patients, you're going to get your basic demographic information. So a little bit about age, gender. So females are usually more predisposed to carpal tunnel as those with advancing age. Patients who are pregnant or patients who are postpartum may again be higher risk groups. The symptoms that your patient may present with are pins and needles. They may have pain and they may have numbness or weakness. And if you ask them, do you find yourself often dropping things or you're struggling with grip? They may say that that's also an issue. And you can see the distribution that's affected here. So it's the radial 3.5 digits. It's also important to find out the duration of their symptoms. Are they intermittent? Do they happen predominantly at night? So have they got nocturnal symptoms? And nocturnal symptoms are found to have a better prognosis in the long run when it comes to treatment that you provide. Also, hand dominance is quite important. So if you have a patient with bilateral carpal tunnel, you may decide that if they're right-handed, you operate on this first so that they can regain their functionality sooner. It's also very important that if in a scenario you're faced with a trauma patient who may have an off-ended distal radius fracture, or for example, a perilunate dislocation, they may have carpal tunnel signs and symptoms. And in these cases, they may require an acute decompression. So some of the past medical history that's quite important, again, these are all risk factors or increase your chance of developing carpal tunnel. So patients who are diabetic, obese, hypothyroid, patients who suffer with rheumatoid or amyloidosis or sarcoidosis or CKD. And a lot of these are inflammatory conditions or conditions that increase edema, and that's why you get compression of the nerve. You can also have space-occupying lesions such as ganglions that could compress the nerve, and that's something to bear in mind, So social history-wise, occupation can be a hazard or hobbies that the patient has. So if they do anything that has repetitive motion or they're working with vibrational tools, for example, all of these increase their risk of carpal tunnel syndrome. And one of the management options may be for them to actually take a seat back and avoid those activities to try and improve their symptoms. It's also vital to find out what conservative measures the patient's already had. So moving on to examination. So as you can see, this diagram here, and I don't know if you can see my cursor, but you can see that there's some thenar wasting going on, and that's usually an advanced or severe sign of carpal tunnel syndrome. When you move on, you'll go on to feel. And when you look at the sensory deficit for the patient, you can do 2 tests. One, if you have the filament available, you can do a 2-point discrimination test known as the Weber test, where you place the filament, which is slightly apart from one another, on the digit affected. And a normal person would be able to tell you that there are 2 different points of contact on their finger. But someone with sensory deficit due to carpal tunnel, for example, may not be able to discriminate. The other test is the 10 test, which is something I use in clinic. So I would touch the patient in the hand in an area that isn't affected and ask them what that is out of 10, which is normally 10 out of 10. And then I would go to somewhere within the median nerve distribution and touch the finger there, and they would then tell me what that is out of 10. Moving on to move. So for this, I always assess the abductor pollicis brevis. And this is because this is an intrinsic muscle that is supplied by the median nerve. So I get the patient to lie their hands flat on a table, and I get them to abduct the thumb against resistance. If you compare this to the contralateral side, providing it's not also affected by carpal tunnel, this would be weaker, and that would suggest a compression of the median nerve at the wrist. If the patient were to have a higher compression, you would be able to find this out because they would also have weakness on flexion at the DIPJ of the index finger or at the interphalangeal joint of the thumb, because of the extrinsic supply to these fingers, once again by the median nerve. So always stick to a look, feel, move, and special tests when you're testing anything in orthopedics. So what are our special tests? So you have the percussion test, which you can see here, and usually we don't use this mini hammer, we just use our fingers, and we percuss over the carpal tunnel, and we see if the patient has reproduction of their symptoms. The other test you may be aware of is Phelan's test. And in that, you get the patient to hyperflex at the wrist for 60 seconds. And sometimes you'll see people try and do this, and you'll see whether they get reproduction of their symptoms. Now, probably the most sensitive and specific test is Durkin's compression test. And in that, you use a thumb and you compress over the carpal tunnel. And after about a minute, you ask the patient if they have reproduction of their symptoms. I exaggerate this by often asking the patient to flex their wrist at the same time and also do it sometimes with it extended to see if that provokes it further. So moving on to nerve conduction studies. Now, I'm not going to discuss this in much detail, but I just think you guys should know that if you have a patient who has atypical findings, for example, or it's not clear because they may have diabetes and have a polyneuropathy of some sort, then you may get nerve conduction studies to confirm your diagnosis. But I think what is key is to remember is that carpal tunnel syndrome is a clinical diagnosis, and these investigations are only needed in certain circumstances. Moving on to differentials, the main ones just to remember are cervical radiculopathy and other peripheral neuropathies. And also, if patients have ulnar nerve symptoms, they may have numbness, tingling, but affecting the ulnar distribution of the hand. So that's just to bear in mind. So what's the management options? So the first line management option is nighttime splinting with a Futuro splint. And this is mainly for patients who have nocturnal symptoms to see if things resolve with that. Again, you may ask them to modify their activities, particularly if they do a job with repetitive motion. The second line would be to consider a steroid injection. And again, most of these are often done in the primary care setting. If this patient does come to clinic, however, and you're administering it, then what I tend to do is I try and palpate for the palmaris longus, which you can do by doing this. If they don't have one, you can palpate for the FCR and go far more ulnar than that. And what you'll feel is a little divot, and you can see the little X on the diagram here. You go in with a syringe, usually a blue needle, with 10 mils of local and 10 milligrams of steroid, or you can put slightly more based on your trust guidelines, and go in at an angle of about 40-45 degrees. You will go into the carpal tunnel and you'll ask the patient to wiggle their fingers to make sure that you're in the right spot. And then when you feel your needle against the tendons, you slightly lift it off and you inject in your steroid. 80% of people with mild symptoms will actually have improvement after this. So if, for example, your patient has severe symptoms, so they have motor signs, so weakness or penile wasting, or they have permanent sensory deficit, or they've tried these first line measures and failed, you will list them for a carpal tunnel release. We tend to do these now under local anesthetic via a procedure called Wallant, which you may have heard of. So this is wide awake local anesthetic with no tourniquet. I use a mix of xylocaine with adrenaline, usually about 10 mils, and I add 1 mil of sodium bicarbonate. It slightly alkalinizes the substance, making it less painful on administration. So you draw your incision, which if you look at this diagram, you can see here, you have your ring finger and you look at the radial border of that and you come down to the distal wrist crease. You then draw Kaplan's line, which is an important line because anything distal to this is where your superficial palmar arch is, and you want to avoid that or avoid any injury to that, sorry. So you draw your incision, it's usually about 3 to 4 centimeters, and then you proceed. Now I'm going to go through the steps by showing you a quick video. So hopefully you can see roughly what you do. So I'll skip through bits. So as you can see, they're drawing a line in line with Kaplan's line there. They're using the radial border of their ring finger, and then they're drawing the incision for their carpal tunnel release. And then I hope you can see that they're now using their scalpel to release the tissues and getting some hemostasis at this point. And then what you'll see is a kind of band of fibrous tissue, which is actually a fascial layer that isn't your transverse carpal ligament. And some people can get confused. So when you see this extra layer, and you'll see it very shortly, they're using blunt dissection to get down to it. And then you can see this layer here. Now, this isn't your transverse carpal ligament. This is the fascia, like I said, and you will release this with your scalpel. And then it will reveal some more fat and possibly a little bit of muscle. So once you've relieved this, I'm just going to go down, try and skip across a bit because we've got quite a bit to cover. You'll see some more fat like you can see in your operative field. And it's really important that you elevate that off so you get a really good view of your transverse carpal ligament. Then once you've got a view of your transverse carpal ligament, you release that a little bit further. And what they're actually doing here is they're using their tenotomy scissors to create a bit of a pocket in the proximal part so that it's easier to release the carpal ligament here. And I don't use a McDonald because the way I've been taught is to do it all under direct vision. But in this case, they've shown that they are using a McDonald to just allow that extension. Now, the key thing to remember is when you release the carpal tunnel, you should release it all the way to the to the palmar fat pad distally. And proximally, you should release it about 1.5 centimeters proximal to the distal wrist crease. And what you should see is tram lines rather than a rugby ball. So if when you look down the tunnel, you see that there is this appearance of something tapering off, that means you probably haven't released it completely. And this is the most common part for incomplete release. You'll then close it with some absorbable sutures so the patient can manage the wound themselves. And then just to be aware of, it's really important that you know some of the complications. So immediately there could be damage to the nerves, such as the palmar cutaneous or the recurrent branch. And that's why you always keep your incision as ulnar as possible and avoid going radial, particularly when you're releasing those extremes of the wound. The thing you can do under Wallant as well is, as soon as the procedure is done, you can actually touch the patient's palm, make sure sensation's intact, and get them to wiggle their thumb. So then you have that confidence that you haven't damaged the nerves. After the first few weeks, you can see the complications there. And with regards to scarring, after the wound's healed, we get people to massage their scar to improve the appearance of this. One of the other things to remember is if patients have worsening of symptoms straight after their procedure, you have to worry that you may have performed an incomplete release. The other main thing to remember is up to 6 months, patients may complain of pain in the palm area. And this is known as pillar or palmar pain. And that's particularly when they lean through the palm or they lift heavy objects. So it's really important you warn your patients of that. I've just written some information about time off work there in case you ever need to write a sick note. That's what you do for each kind of job. And I will end it there because we don't have a lot more time. But if any of you have any questions, please put them in the Q&A area and George can ask me them.
That was great. Thank you, Kriti.
There's Q&A at the moment. So I don't know if we want to just crack on with Alison's talk, and then if anyone has any questions for Kriti or Alison, if you type them out as we're going, and then we can come back to them at the end.
Yeah, that'd be great.
Okay, can I just check, can everybody hear me and can you see my slides okay? Give me a thumbs up, Kriti. Brilliant. Right, good evening everyone. Noswitha from Wales. My name's Alison, I'm one of the registrars here and one of the members of the BOTA committee. And I have the joy of dealing with this topic. So tell me about carpal instability, I think is one of the questions that instills fear into the hearts of almost all orthopaedic trainees. I think that this would be a not uncommon reaction to having to deal with that topic. It's an incredibly broad and complex topic. And I can't stress strongly enough that we've got a leading hand surgery expert joining us for this Sunday supper at 8 o'clock, who will be going through this in far more depth. So what the brief is for this evening, what we're going to do now is I'm really going to talk to you through the very basics of some of the more common areas of carpal instability that you might get asked about. So starting from the ground level, what is the carpus? Well, we're talking about the 8 small bones that sit between your forearm and the start of your metacarpals. And they're roughly aligned, as you see, into a proximal row of the scaphoid, lunate, triquetrum, and pisiform, and a distal row of the trapezium, trapezoid, capitate, and hamate. Now, why have we got such an incredibly complex arrangement? You know, if you look at the number of interlocking surfaces and joints within the carpus there, why have we got something so complicated? Well, it's all because of what you're expecting the hand to do. So the wrist and the carpus, along with the radius and ulna, are responsible for trying to get your hand into any position in space, as well as being able to do sort of fine manipulation of objects between your two hands. So that means it has to be exceptionally mobile and finely tuned, but also it's got to be incredibly stable. You know, you've got to be able to take an impact with your hand. You've got to be able to lift a heavy weight. You know, looking far enough back in your family tree, you've got to be able to swing from a tree with your hand. So it's got to be both really mobile and really stable. And the carpus does do all of that, but it does it with this very, very complex arrangement. The other thing to bear in mind is that the movement in the carpus is predominantly due to extrinsic forces. So there's very scanty muscle attachment within the carpus itself. It's predominantly just transmitting and modulating forces that are happening to it from either the forearm side or the metacarpal side. And this is particularly true of what we call the intercalated segment, which essentially refers to the proximal row here of the scaphoid, the lunate, and the triquetrum. Now, what's holding all this arrangement together? Well, it's ligaments, and so many ligaments. We are absolutely not going to run through all the ligaments of the wrist now, because it will take an age. So you see this first. Here's a diagram of some wrist ligaments, and you think, that's not too bad. There's only a couple on there. But then you add this diagram to it, and then you add this diagram to it. There are so many ligaments. Literally name any 2 bony structures in the wrist, and there will be a named ligament running between them. There are a myriad of them. But we're just going to concentrate today on the 2 which I would argue are probably the most clinically important, which are the scapholunate ligament here and the lunotriquetral ligament on the other side. So why are we talking about those? Well, we're going back to that proximal row, that intercalated segment, and looking at how that works. So we've got, in this very high-tech diagram that you can see here, we've got the 3 bones of that segment, the scaphoid, the lunate, and the triquetrum. And as we've just seen, these are tied together nice and strongly by a scapholunate ligament and a lunotriquetral ligament. Now, this setup is permanently under a certain amount of torsional stress. So basically, because of the pull on these bones and on these structures from outside, it means that the scaphoid is permanently trying to flex forward, flex volarly, whereas the triquetrum is permanently trying to extend. So this sort of tube of structures is permanently sort of undergoing this twisting force, and as long as everything is tied together and the lunate is sat there in the middle, this is balanced and everything stays stable and everything works just as it should. What happens though if we break a bit of this mechanism? So what happens, say, if we have an injury where we snap the scapholunate ligament, which is a not uncommon injury? Well, what happens then is the scaphoid is now unrestrained. That can fall nicely into flexion as it's always wanted to do. There's nothing holding it back anymore. Whereas the triquetrum is able to loll back into extension, to go dorsally, and that then is able to drag the lunate with it because it's no longer being held in alignment. So the lunate and the triquetrum, as they extend, so they go dorsally, this system is now unstable, and therefore that's why we call it a dorsal intercalated segmental instability, which is commonly abbreviated to a dizzy wrist or a dizzy deformity, which you may hear talked about. Now, given I've gone on and on about how incredibly complex and finely tuned the carpal mechanism is, do we think that uncoupling part of it and making it unstable and having bones falling into all sorts of odd positions will have an effect on the wrist? Of course it will. You know, what happens when you've got joints all malaligned and rubbing in ways that they shouldn't rub? Arthritis happens. So I'll go back to that slide in a second. So what you then get is what we call a slack wrist. So this is what we call scapholunate advanced collapse. It's not important at junior stages to know about all the different stages of this, but it's just to show that if you uncouple that mechanism and you have the wrist moving in an abnormal fashion, you get quite a rapidly progressive arthritis that is centered all around the scaphoid. And because it's happening because you've broken the scapholunate ligament, it's called scapholunate advanced collapse. All I was going to show you on that previous slide, which I clearly forgot was there, is just that you can see dizzy deformity sometimes on the x-rays. It's not all that simple to point out, but if you can see on the lateral x-ray here, you've got the nice sort of half moon shape of the lunate up here, pointing nice and vertical. And then this line, take my word for it, is showing you the axis of the scaphoid. And so this is how it should look. If you compare it to this picture here, you can see that the lunate has started to tilt backwards a little bit, whereas the scaphoid has flopped all the way forward, meaning that that angle has become significantly increased. And you can sometimes see signs of this on an AP X-ray as well. So what you can see here is the arrow showing you this great big gap here between the scaphoid and the lunate, showing you that that ligament has busted apart. But what you can also see is this sort of ring here on the scaphoid, and this is called the ring sign or the signet ring sign. And it's just a sign that because that scaphoid has been allowed to flop forward, you're now looking at it end on, and it gives you this sort of ring appearance. So these are all signs that could suggest a dizzy deformity. And as I just said, that then can predispose you to go on to slack pattern of arthritis. So what happens if we break somewhere else in this chain? What happens then? What happens if we break the lunar-triquetral ligament, which is not as common as an isolated injury, but allows us to look at how this mechanism works? Well, what happens then is the triquetrum is free to fall into extension unrestrained. But the scaphoid is still trying to force everything forward and go into flexion. And that then pulls the lunate forward. It pulls it volarly, and therefore this is known as volar intercalated segmental instability. As I said, this is rarer and it doesn't have the same sort of arthritis pattern related to it, but it does give you a dysfunctional wrist in some states and some circumstances. And again, you can sometimes see this malalignment on the lateral X-ray here. So you can see that this lunate has tipped forwards, and it's almost collinear with the scaphoid, and with a very narrow angle between them there. And what I've got here is a slightly more high fidelity way of looking at the same thing. So hopefully this will work nicely. We'll skip forward to about there. So some lovely lift music as it shows you the proximal row here with the scaphoid, the lunate and the triquetrum, with those inbuilt tendencies producing the torsional stress. What happens if you snap the scapholunate ligament? You get a dorsal intercalated segmental instability. And it shows here how that all falls out of alignment. What if we go the other way and snap the lunar-triquetral ligament? Well, the opposite happens. It falls out of alignment in a volar direction. Lovely. I think we've had quite enough of that music. Right. Now, is it only ligaments you can break in the wrist? Well, of course it's not. You can break the bones too. And which bone in the wrist do we know is often fractured and is a real pain in the neck for everybody? It's the scaphoid. So you can see here, if you snap your scaphoid in half and it doesn't knit back together, then again, you've broken this chain, which means that the end bit of the scaphoid, which is the most distal bit of the scaphoid, that's still attached to what it's supposed to be attached to. So that will fall into flexion again. That'll be pulled into flexion. But the rest of the scaphoid with the lunate and with the triquetrum will carry on being pulled back into extension. And this means that, again, you've decoupled this mechanism. Everything's out of alignment. Everything's moving in ways it shouldn't move. And what happens then? arthritis. So this is called a snack wrist, as opposed to what we had before, which was a slack wrist. They sound very similar. They in fact are very similar because it's the same kind of mechanism that you've decoupled. You've just decoupled it in a slightly different place. So this is scaphoid non-union advanced collapse, because that's the cause of why this wrist is collapsed. But again, the thing I would stress is it's just a quite rapidly progressive and predictable pattern of arthritis that is centered around the scaphoid and the radius scaphoid joint due to the injuries that we've talked about. So this leads me nicely on to getting near the end of this session to the question of, why is everybody so obsessed with the scaphoid? Like, if you work in A&E or if you work in a fracture clinic, you will spend an inordinate amount of time peering at scaphoid x-rays, you know, trying to trace tiny lines that might be fractures, and putting people into casts for query scaphoid when frankly you can't see anything at all, and poking people in the anatomical snuff box. Why are we so het up about scaphoids? What is it about them that means they take up so much of our time? Well, there's a couple of reasons for that. Now, I haven't had to anonymize this picture because this is my husband's wrist and he is delighted that his injury is receiving national prominence tonight. So, and it neatly illustrates a nice standard scaphoid fracture. So as you can see, these are not uncommon because I really didn't have to go very far to find an example of a scaphoid fracture. And they tend to happen in young people. So people in their teens or in their 20s, and Leif was in his 20s when this happened. And that's because it's the weakest link when you fall in an outstretched hand in that age group. Kids break their distal radius, elderly people break their distal radius, young adults break their scaphoid. Now, and this is as I say, it's fallen outstretched hand, which is exactly what he did. He went over the front of his mountain bike, bang, scaphoid broken. Now, this is obviously not hard to see this one. I mean, frankly, you could drive a bus through this scaphoid fracture here, but they are often really sneaky. So the scaphoid is a really awkward three-dimensional shape, and you're looking at it with x-rays which are two-dimensional. If you have a relatively undisplaced fracture, if you don't have the beam of the x-ray exactly lined up with the angle of the crack, you might not see it, particularly on the initial x-rays, which is why you'll have lots of scaphoid views taken at all slightly different angles to try and look at this. And you also will sometimes bring the patient back for x-rays in a couple of weeks just to check whether there's that crack there. And the problem is, so we've got a common injury that's easy to miss. And if you miss it, the results can be catastrophic. So we've already looked at the fact that if this fracture doesn't unite, if it doesn't heal up by itself, so say you just leave the patient and say, oh, you've just sprained your wrist, you'll be fine, and they carry on moving their wrist and the fracture doesn't heal, we've seen that that can lead to very rapidly progressive arthritis and that snack wrist that we talked about. Alternatively, you can get a problem called avascular necrosis. And this is because, and I suspect most of you have heard this, the blood supply to the scaphoid is not very well designed. So it's a bit like you hear people talk about the femoral neck with those kind of fractures in the elderly. The blood supply sort of circles back on itself and goes backwards, which means that if you snap the scaphoid across here, you can easily cut off the blood supply to a section of the bone, and bone without blood supply basically dies. So that's what we call avascular necrosis. And the combination of all of these factors means that the scaphoid is an absolutely prime area for litigation, because you've got young, active, working people who've had an injury that you might be able to point out on the x-ray that has then not been treated and has caused them to have a really disabled, arthritic, basically ruined wrist. So it is absolutely prime for litigation, and this is one of the reasons why everyone is always absolutely obsessive about not missing scaphoid fractures. Just in case you were worried, I'm pleased to report that nobody missed that scaphoid fractures of late. His was fixed nicely with a screw, as you can see here, and unfortunately for all of us, it in no way put him off his mountain biking. So lovely, that's all from me. I will stop wittering on and refer you back to George.
Great, thanks, Alison. There was one question in the QA, which is probably more for Kriti, but I'll open it up to the floor. So, multi-part question we've got here. So, in the setting of distal radius fractures with acute carpal tunnel syndrome, what time should you aim to perform your release? Is it indicated in every case? For example, a well-reduced stable fracture with carpal tunnel syndromes, keep elevated, plan for morning theatre, home elevate, etc., etc.
Okay, yeah. So with regards to this, it's very much, like you said, common sense, and you've kind of answered your own question very well. So if you have a displaced fracture, the first thing you're going to do is try and reduce that. And if you are able to reduce it so that you can remove the compression off the median nerve, then that's completely fine. I would then leave the patient in a back slab, in a Bradford sling with their arm elevated, keep them in overnight for observation, and then the next morning reassess them and see how their median nerve symptoms are. If it's that displaced a fracture, and usually for it to affect the median nerve, that means that the distal fragment of the radius has moved volar, and they tend to be unstable injuries anyway that then require fixation. So then that patient will most likely be listed on the next available trauma list, and most likely the next morning, particularly if they had neurology or median nerve symptoms. And then at the same time as having the fracture fixed, they would also have their carpal tunnel released. So that's how I would manage it. I don't know if Alison or George have any other opinions on that. Obviously, if it's a perilunate dislocation or something that you can't reduce in A&E, then it may be that overnight you would then have to take that to theatre, but that wouldn't be you yourself. Even we wouldn't do that. We would probably contact our boss before you take anything to theatre. And for the interview, that's the key question. If you're going to take anyone to theatre, always say you're going to contact your senior. It doesn't matter what grade you are. You're not going to take anyone to theatre without that. So obviously make sure you've done the plan, you've prepped the patient, but you're going to have a chat with your boss and then take someone to theatre if need be.
Yeah, so I'd agree, Kriti. I think for anyone who has a neurovascular compromise, first thing is to try and relieve the tension on the nerve. So reduce the fracture, casts, dressings, splits, all the way down to skin, top to bottom. Make sure they elevate the wrist. If it's improving, monitor it. If it's getting worse, then you need to consider doing something about it. And I think that you can apply that to pretty much any nerve injury anywhere in the body. If it appears it's deteriorating, you might need to do something about it. And with regards to timing, it depends on, I guess, the time of day, the capability of the on-call surgeon. Some might want to do it that night. Some might say it's 2 a.m, the trauma list starts at 8. We could leave it a little bit longer. But I think, if you're that worried and it's rapidly progressing and you're concerned, time is nerve tissue and time is muscle tissue. So sooner rather than later. And I don't think you'd for an interview and junior sort of level, saying you discuss it with your senior and your boss earlier rather than later is the right thing to do. I think that's all we've got in the Q&A. I've got a couple of slides for shameless promotion for BOTA whilst everyone's here. So first announcement is that our plans for Congress this year, due to the ongoing COVID-19 situation, we've decided that we will be running a virtual Congress later this year, and there'll be more information coming out about that as soon as it's available, but just a wee heads up to everyone. And to those of you in the audience who are more senior and thinking about going on fellowship soon, we've just launched a new website, which is the Fellowship Finder, which is a great resource for looking for information about fellowships. So if you just go to just Google Fellowship Finder, sign up for an account, it's totally free, and you can get some information about potential fellowships. Great, well, we'll end it there. So thanks everyone for coming. For those of you who'd like to join us for the later session, the Sunday supper, we'll have some more excellent talks from some consultants in a bit more detail aimed at the FRCS level, but anyone is welcome to join. And I posted the link in the chat. And for those of you who want to watch this back later, the video will be embedded on our new BOTA website when it goes live. The plan for that is hopefully later next week.
Yeah, I was going to say, because I had to rush through the operative procedure for carpal tunnel, so that will be available on there, so you guys can watch that in kind of slow motion and go through it yourselves, so you feel more confident when you have to do it in theatre yourselves. So, all right.
And then the final thing to say is you'll get a link to some feedback. So if everyone could fill that in, it's a Google form. It's like 5 questions, and it just really helps us to improve these sessions and keep them running. So that'd be great. Right. Thanks, everyone.
Yeah. Thanks, everyone. See you later. Bye.